Okay, so the title of our study is Effect of Aspirin on Disability-Free Survival in Healthy Elderly. It's a randomized, double-blind, placebo-controlled trial. So it's looking at the overall effect of taking low-dose aspirin daily to help prevent development of disability later in life. These patients are elderly, community-dwelling patients that are 65 or older. They focus on death, dementia, cardiovascular, physical disability, and also the risk of major hemorrhage.
So we know that a lot of our patients are taking low-dose aspirin for primary prevention, but is there really a lot of evidence to support this use in the healthy geriatric population? So we know that aspirin irreversibly inhibits platelet aggregation, so it decreases the risk of thrombotic events. However, it increases the risk of bleeding, particularly in the geriatric population. So it's widely used and recommended for secondary prevention. However, the evidence surrounding primary prevention use of aspirin is a little bit more controversial now. A lot of recently conducted primary prevention studies have shown less benefit for prophylactic aspirin than we once thought. The uncertainty is now being reflected in many guidelines around the world, with a shift being towards patient individualized decisions based on their risks and their benefits. Our study was actually referenced in the 2019 American College of Cardiology American Heart Association guidelines on primary prevention of cardiovascular disease, with their new recommendation being shifted towards this individualized approach for our patients based on the balance of their risks and their benefits.
Okay, so just to break down the study even further, the population is healthy, community-dwelling elderly, 65 or older, so they can live by themselves independently. It's conducted in the United States and Australia. Each patient has no cardiovascular disease, dementia, or physical disability. The intervention is 100 milligrams of low-dose aspirin, while the comparison is identical looking placebo. The outcome, however, is that there was no true evidence to suggest that it prolonged disability-free life in these patients. And the result of primary endpoint of death, dementia, and physical disability in the aspirin group, it was 9.7%, while the placebo group was 9.5%.
This was a computer randomized RCT. There were over 9,000 people in both the aspirin and placebo groups. And the two groups were similar on a demographic and clinical basis, but they were predominantly white. So in a racially diverse setting, this study might not be as applicable. There was also a 4-week run-in phase where the eligible participants were tried for adherence. And if their adherence rates were more than 80%, only then would they move on to the randomization phase. So this could be a little bit questionable, as do all the elderly 65 plus always have an 80% adherence rate to their medications daily. This trial did do an intention to treat method, so even if patients withdrew their consent or if they were lost to follow-up, their results were still included in the final analysis and their vital status was taken before the end of the trial. The trial did stop after 4.7 years instead of their intended 5 years of follow-up, due to them analyzing their data and finding out they had a 1.01 hazard rate. So this meant that the aspirin group actually had more of a chance of the primary outcomes than the placebo group.
So we get a lot of questions every day about over-the-counter products, but more specifically about aspirin and whether or not patients should be taking it. So we can ask the patient if they've had a cardiovascular event before, and then we can determine if it's going to be used for primary or secondary prevention. So if they have not had an event before, maybe the aspirin should not be recommended because it can lead to a higher risk of hemorrhage and bleeding. But if they have had an event before, it can provide cardiovascular benefits. And this can also be an opportunity for deprescribing. So we can screen our patients who are taking aspirin daily, particularly elderly patients, and start a conversation with them, ask them if they've had an event before, and we can collaborate with their physician to determine further steps if necessary. So many patients are currently taking aspirin daily, or they're considering it, but recent studies have shown that taking it for primary prevention is not as beneficial as we thought it was. So we can use this evidence to take a more individualized approach for our patients based on their risk factors.